Welcome to this recorded webinar of Omics course entitled Duty to Patients, Beginning, Ending, and Obligations. To have as my co-presenter, Dr. Bob Wiggins. Bob is a pediatric and neuro-ophthalmologist who practices in Asheville, North Carolina. Welcome, Dr. Wiggins.
Thank you, Ann.
And I'm obviously Ann Menke. We have no financial disclosures, but we're both affiliated with OMIC. Dr. Wiggins is the chair of our finance committee and a member of the claims committee, and I'm OMIC's patient safety manager. We're going to start by going over the legal elements of medical malpractice so you understand what the patient who becomes the plaintiff has to prove in order to be successful. So these are the 4 Ds. The first is a duty to treat the patient, and the entire course is going to be on that. Next is a deviation from the standard of care. And there's no enduring standard of care. This is what the expert witnesses in each case testify to. It's usually defined as what a reasonably prudent ophthalmologist would do in the same or similar circumstances. There has to be a direct causal relationship between the deviation, what you did or didn't do, and the alleged injury damages, and this is also known as proximate cause. This is really important because in some cases, we admit to a deviation from the standard of care, but argue that it didn't cause the injuries. And so we can win some cases on the cause. Finally, there are damages, actual economic damages, lost wages, costs of current and future medical care, and non-economic, otherwise known as pain and suffering. If we make a payment on behalf of a defendant, that's called an indemnity payment. This was actually the one who suggested this topic for a course. And indeed, we get so many questions both on the hotline and anytime we're presenting OMIC courses about duty. So here's some of the most important ones that we're going to try and address today. When does the physician-patient relationship begin? Once it begins, what duties do you owe to the patient? When does the relationship and duty of a referring physician end? When does it begin for the physician to whom the patient was referred? If someone just shows up at your office, do you automatically have a physician-patient relationship? And you need to formally end it. So I'm going to pass this now to Dr. Wiggins, who is going to go over a case of a referral to another physician.
Thank you, Ann. This first case involves the referral from a retinal specialist to a neuro-ophthalmologist, both of whom were defendants in this particular case. This case began on June 25, 2015, when an optometrist referred the plaintiff, who's a 22-year-old female, to the retinal specialist. He was concerned about the possibility of a retinal detachment related to a 6-week history of darkness of the peripheral vision in the left eye. And on the exam, the visual acuity was 20/25 in the right eye and 20/50 in the left, and there was dramatic disc edema in both eyes. And the retinal specialist's impression was that this was likely pseudotumor cerebri or idiopathic intracranial hypertension. So the retinal specialist contacted a neuro-ophthalmologist by phone. The neuro-ophthalmologist was not in the office that day, but agreed to see the plaintiff within a few days. And so the retinal specialist staff escorted the patient to the neuro-ophthalmologist's office, which was next door. The patient and her mother were met by the neuro-ophthalmologist's wife and office manager and assistant, who spoke with them and told them that the neuro-ophthalmologist was not contracted to see public aid patients. She was offered to be seen as a self-pay patient, which the plaintiff declined. The neuro-ophthalmologist's wife told the plaintiff she would need to go see a neuro-ophthalmologist at a nearby university and gave her some contact information and said she advised the retinal specialist that the neuro-ophthalmologist would not be seeing the plaintiff. Well, that day, instead of doing that, the plaintiff called her primary care physician for a next day appointment. And the next day, she saw her primary care physician and said she was told that she would need to see a neurosurgeon and have a spinal tap. Well, the nurse told the plaintiff it could take weeks to find a physician to see someone who was on public aid. An appointment was made with a neurologist for July 22nd, 2015. Well, on July 3rd, while waiting for that appointment, the plaintiff called back to the primary care physician saying that the vision was getting worse. And the primary care physician then referred the patient to the community hospital emergency room. There she had a head CT scan, which was normal. She was discharged, no treatment was rendered, and she was told to keep her appointment with the neurologist. Well, the plaintiff's mother called back on July 10th, back to the primary care physician's office, and said the vision was continuing to worsen. So the primary care physician directed the plaintiff to a second local emergency room where the neurologist that she was going to be seeing happened to be on staff. And when that neurologist was called, he recommended that the plaintiff go instead to a university hospital. So the patient was seen at the university hospital on July 10th. Now this was, as you recall, 15 days after she originally presented to the retinal specialist. Her vision was now hand motion in the right eye and light perception in the left eye. There was 4+ optic disc edema bilaterally. A head MRI and MRV scan were negative, and the opening pressure was elevated on lumbar puncture. She was diagnosed with fulminant idiopathic intracranial hypertension and treated with intravenous methylprednisolone, acetazolamide, and a lumbar drain. And on the 12th, had a bilateral optic nerve sheath fenestration. On July 21st, visual acuity had improved in the right eye to 20/30-2, but there was marked concentric visual field constriction with only 5-degree central island. The left eye remained the same, and 2 years later, there was no change in the visual function. Well, while things were going downhill in this case, the retinal specialist and neuro-ophthalmologist had no other contact with the plaintiff until a claim was filed. And initially, this was against the retinal specialist and the primary care physician, but then later the neuro-ophthalmologist and that practice was brought into the claim as well. And then there was a discovery bombshell. And here is that bombshell. On the visual field machine in the neuro-ophthalmologist office was found a visual field from the date the plaintiff had initially seen the retinal specialist and been taken over to the neuro-ophthalmologist's office. And you can see here in the right eye, the less affected eye, peripheral visual field constriction and more marked visual field constriction, particularly nasally, in the left eye. Well, during the deposition, the office manager at the neuro-ophthalmologist's office denied she performed that visual field, and yet the plaintiff and her mother said she was indeed the one that performed the test, and they recalled specifically her behavior. And all indications were that she did perform the test, although she claimed it must have been done by the retinal specialist. It was unclear who had actually ordered the test, though apparently the results were not released to either doctor, and the results remained on the machine. The retinal specialist in his testimony said that the visual field was not performed at his office and said he was not notified that the neuro-ophthalmologist would not be seeing the plaintiff, and so separate legal counsel was assigned to these two defendants. Now, the experts on either side for the plaintiff and defense had to answer several questions about duty. Did the retinal specialist owe a duty to the patient once he transferred care? Did the neuro-ophthalmologist owe a duty to the plaintiff? Was the neuro-ophthalmologist required to inform the retinal specialist he would not be seeing the patient? Well, there were strengths and weaknesses for each of the defendants, and there were actually 4 defendants here. There was both the retinal specialist and his practice, or the entity, and then there was the neuro-ophthalmologist and that practice or entity. So on the retinal side, The retinal specialist did suspect the correct diagnosis and made a prompt referral to a neuro-ophthalmologist. And there were multiple other co-defendants who had the opportunity to diagnose and treat the plaintiff. The retinal specialist was felt to be an effective witness, and the plaintiff did fail to follow the instructions that were given to seek the necessary consultation. Weaknesses were that the plaintiff would be sympathetic to a jury who had the plaintiff being nearly totally blind, and then there were discrepancies between the retinal specialist and neuro-ophthalmologist office manager's version of events. On the neuro-ophthalmologist side and the practice, the strengths were, well, the neuro-ophthalmologist never examined the plaintiff. The plaintiff was offered the opportunity to be seen in that practice as a self-pay patient. The plaintiff was given contact information for neuro-ophthalmology at the local university, but the plaintiff instead contacted the primary care physician. On the other hand, weaknesses for this side were that the neuro-ophthalmologist did agree to see the plaintiff. And the plaintiff actually was seen in the neuro-ophthalmologist's office and had a visual field test performed by his assistant. The neuro-ophthalmology assistant's denial of performing the visual field test did not appear credible, and the profound vision loss should have prompted greater involvement in assuring timely evaluation by the neuro-ophthalmologist. In other words, effort should have been made by this office to make an appointment rather than putting the responsibility on the patient to schedule the appointment. And this was the outcome. The vision 20/30 in the right eye with marked visual field constriction and hand motion at 2 feet in the left eye. The neuro-ophthalmologist was dismissed. The entity or practice of the neuro-ophthalmologist settled for $1 million. The retinal specialist in his practice went to trial. The retinal specialist was dismissed during the trial, and the jury voted in favor of the retinal specialist entity or practice. So now I'll turn it back over to Ann to discuss the risk management considerations in this case.
Thanks, Dr. Wiggins. So as you can see, there were a number of problems with this referral, and we see this often in lawsuits. The plaintiff, as Dr. Wiggins stated, went the following day to her primary care's office and handed him a single-page note that said pseudotumor cerebri, lattice degeneration, and papilledema. There was no name on the note. We never figured out who actually wrote it. Nonetheless, the primary care copied this information into the patient's record. During his testimony, he said he had never heard of pseudotumor cerebri and didn't understand how urgent it was. He just knew it was some kind of neurological condition. She needed to see a neurologist. He also knew that she was going to have trouble finding a local neurologist, and that's why he asked his staff to help her. This is a form we developed to help with these situations. As you can see, it's very brief, just says who's being referred, gives the patient's phone number, explains whether the appointment will be made by the patient or scheduled by the referring physician's office, gives the reason for the referral. Really important, what input is needed, what do you want to know after this referral, and then clearly indicates the timing of the referral. From the patient's perspective, it's really important to make sure the patient understands both the reason for the referral and when the care is needed. If not, the patient could later allege something called lack of informed refusal, which is the corollary to lack of informed consent. So we've developed a form for the patient. You give this to the patient, and it has all the key information, including the reason for referral and the timing. And interestingly, but importantly, at the bottom, it also says if you can't schedule it, call us. And if there are any changes, call us. So when does a referral duty end? Obviously, you have to confirm that the appointment was scheduled. And by the way, we're talking here risk management. Your defense attorney may make different arguments, but we don't want you to end up in court or be sued. So here are our risk management recommendations. It doesn't end until you confirm that the appointment was scheduled, which raises the issue of who should schedule it. Take into account what could possibly happen if the patient doesn't schedule it. We recommend you schedule it for the patient if there's a significant risk, as in this case, patient is a minor, or if urgent or emergent appointment is needed, because your office is going to have much more luck getting that kind of an appointment than the patient. So the second thing of when the duty ends is you get the results back and you then communicate them to the patient. We've had a number of cases where the patient never heard the results, didn't know what further care was needed. So follow up on input from a consultant. The day you're referring the patient to the consultant, we recommend you make an appointment for the patient to return to your office so you can discuss what you've learned and what the care plan is. Always schedule that before the patient leaves your office, and then that'll be in your tickler system. Also, keep a file to watch for results and then inform the patient of the input and care. Put in the file when you expect the results. If you haven't received them, have your staff call the physician. And if the patient never went for the appointment, then call the patient to find out why. Dr. Wiggins is now going to present a case of referral to an academic center.
Thanks, Anne, and you'll see some similar themes in this case as well. So this patient saw the insured at age 2 years. The visual acuity was equal, anisocoria was noted, and there was no strabismus. The optic discs were noted to be gray, and there was the possibility of optic disc drusen noted in the left eye. So on the first follow-up visit, which was 1 year later, it was difficult to assess the visual acuity monocularly in this young child. It was tested at 20/70 bilaterally at near. Optic disc drusen were noted, and it was questioned whether there was optic disc pallor on both sides. So the ophthalmologist wrote a referral letter to a specialist at a university requesting further evaluation. At the second follow-up visit, which was now another year later, the ophthalmologist learned the patient was never taken to an academic center. The visual acuity was now decreased to less than 2100 in the right eye, and it was questioned whether the child had an optic neuropathy or amblyopia. No definite afferent pupillary defect was noted, and bilateral optic disc pallor was seen. The patient was again referred for university consultation. It wasn't clear why the appointment wasn't made. A letter had been written to the physician at the university, and the referring doctor noted in his second letter that possibly the ball had been dropped in scheduling that appointment. Well, on that consultation at the university center, the visual acuity was 2160 in the right eye, normal in the left. Disc pallor was noted bilaterally. The workup revealed increased intracranial pressure, a shunt was placed, and there was no further loss of vision. Well, the defense experts who reviewed this case said the ultimate responsibility for assuring consultation lied with the referring ophthalmologist, and it was unclear if the consulting physician, who in this case had gotten a letter, at least the office had gotten a letter, did that practice have some duty to contact the patient when the appointment was scheduled? Well, the claims outcome in this case, it was settled at mediation on behalf of the referring ophthalmologist for $425,000. And now to Anne for the risk management considerations.
Thanks again, Dr. Wiggins. So again, we're continuing to ask, do you have a duty? So if you get a referral letter, as the university physician did, from another physician, but no appointment is ever scheduled, do you have a duty? So there are two ways to look at it. From the patient's perspective, does that patient have a reasonable expectation of care? Was the patient given your name and address and told you would provide the care? That's going to lend credence to duty and having established a relationship. From the physician side, the AMA Code of Ethics notes that the relationship is generally entered into by mutual consent. And the question they ask is, does the referring physician have a reasonable expectation that you'll accept the referral? If you regularly accept referrals from this physician, again, that's going to give more credence to the plaintiff side and that you did have a physician-patient relationship. What about if you get test results for a patient you've never met? You didn't get a referral, no letter, just test results. We don't believe that there is any requirement to follow up on those. So when does the duty end when a patient is referred to you? It ends if you're not going to be providing ongoing care. Make sure you inform the patient who will be providing the care, send a letter back to the referring physician with any advice about management, and state in the letter that the referring physician will be the one taking over care. That makes it very clear to everyone. If you're not going to provide any care, your role was just to do an exam, tell the patient you won't be informing care and explain how to get care, or you can arrange for timely care somewhere else. That one was short and sweet for the risk management perspective. So we're back to Dr. Wiggins to present a case of on-call duty.
Thanks, Ann. Well, this case does involve being on call and what duty is involved when you are on call. You'll see some recurring themes again in this case. This was a 2-year-old who fell into oily matter in the driveway and presented to the emergency department. And the ER physician called the insured ophthalmologist on a Sunday to report a diagnosis of a corneal abrasion with an acute inflammatory response. Well, the insured was leaving on vacation and did not alert the office about the ER consult, but told the mother to bring the child to the office the next day. Well, the mother did the child to the office the next day. They did not identify themselves as a referral from the emergency room, and they reported the child had a pink eye. Well, they were told at the front desk that the office had a policy of not seeing public aid patients. Next slide. Well, the child was ultimately seen at the local children's hospital 2 days later by a pediatric ophthalmologist and a corneal specialist who diagnosed a significant corneal ulcer, which led to permanent decrease in vision. The plaintiff expert opined that the failure of the office to see the ER patient when covering call for the hospital constituted malpractice, and that the failure to diagnose the corneal ulcer led to irreversible vision loss. The defense said that the insured met the standard of care with a phone consultation with the emergency department, but the handoff to the office was troublesome, and that the office not seeing the patient was concerning. The patient had amblyopia as a result of the delay in care, which fluctuated between 20/40 and 20/70 with patching and felt to be a significant issue. Well, this case went to trial. Settlement negotiations were made, but the corporation lost key motions to keep out the fact the patient was turned away because they were on public aid. It was felt this was too inflammatory. It turned out the doctor who was on call for the emergency room that Sunday was an associate of the practice who did see patients on public aid or Medicaid. But the owner of the practice, who was there the next day, who was not informed the child would be coming in, did not accept Medicaid patients, and that's where the problem arose. So in this case, the corporation, the entity, settled for $1 million, and the doctors were dismissed from the case. So now to Ann for risk management.
Thanks, Dr. Wiggins. So what is your duty if you're on call to the ER? First of all, when does it begin? Only if you're on call that day for that emergency department. You may get calls, emergency department physicians are frantic trying to find specialists. But if you're not on call, tell the ED, I'm not on call today, please check the schedule. The ED is required to have a backup plan, which essentially consists of transferring the patient to another hospital that has the needed services if they can't provide them. So if you're on call that day and you're either contacted by the ED physician and you speak on the phone, or you go in and examine the patient, then you've established a physician-patient relationship. Do you have follow-up duty as an on-call physician? If it's your own patient, you do, as you would any of your other patients. There is no follow-up duty for physicians in EMTALA. It's the hospital that has to make sure there's follow-up care available. However, if your hospital staff bylaws address this, they are considered to be an extension of EMTALA, and then EMTALA still applies. So make sure you check them to see if you're required to provide outpatient care. If you speak with the ED physician or go in to examine a patient, or indeed, if you're expected to provide outpatient care for any patient who needs ophthalmic care. So when you're on these phone calls with the ED, you need to do what I call drive the conversation. You will be considered the expert. There's a higher standard of care for you. And so you need to ask all of the questions about the history, about what was done during the exam, about the exam results, until you're certain you have all the information you need to decide if you need to go to the ED or if you can safely help the ED physician treat this patient over the phone. Please document your phone calls with the ED physician. Often this is your only involvement in a lawsuit. And if you have no documentation, it's much, much more difficult to defend you. It's also really important to clarify and document who has follow-up responsibility. Make sure the ED physician, the patient, your office, and the hospital all know who will be taking care of this patient. If you will be providing the outpatient care, don't go on vacation without telling your office to expect a patient. And if you know of any circumstances such as public aid that might conflict with the policy of other physicians in your practice, make sure your office staff knows that you do indeed plan on seeing this patient. If the patient doesn't follow up, we really feel strongly that you should. Sorry, if the patient doesn't make the appointment or show up, we feel you do need to follow up. This should be considered an urgent situation, and a minimum of follow-up can usually keep you out of a lawsuit. We have a non-compliance toolkit on our website, and there's a sample letter that says the ED physician felt you have a condition that could cause vision loss. You don't know what the diagnosis is. You have no specific advice. Obviously, you need the patient's contact information to be able to send a letter. When does your duty end? Either when you've provided the needed care, you're not asked to provide ongoing care, or this is rare, but it happens that you've already terminated this patient from your practice. You're required to provide on-call care to any patient if you're on call. But if you've already discharged this patient, you're not expected to provide outpatient care. So again, both the patient and the physician need to know, and arrangements need to be made. A couple of these cases have brought up the issue of declining to see patients. So may you have a policy of not seeing public aid patients? You do have some choice about which patients you see. So you can choose not to see patients if none of the following apply. The patient isn't protected by the ADA. We get a lot of calls about patients who are deaf, who need sign language interpreters, who are very expensive, don't show up. So some of the physicians say, do I really have to accept this patient or continue to see this patient? Yes, because deafness is an ADA issue. If, however, that patient has other issues for which you terminate any other kind of patient, then you may terminate. So if the patient's not protected by the ADA, you have no contractual obligations, for example, with the patient's health plan, and you don't have a pre-existing relationship, then you may decline to see the patient. However, if the patient presents to your office as this child did, especially if it's a child, it's safest to examine the patient, provide either the emergent or stabilizing care, or provide urgent care or arrange for another physician to do it in a timely manner. That's much, much safer for you and the patient. If you're not going to continue to provide care, send a termination letter, and there are sample letters in our termination toolkit. For duty when you're not on call.
Thanks, Anne. So this will be the flip side of the last case. What about duty when you get called for an emergency and you're not actually on call? So this was a 30-year-old male who presented to the emergency department who reported a chemical was splashed in his left eye while he was disposing of garbage while working at a dry cleaner's. His eye was irrigated in the emergency department. No pH testing was done. And a call was made to the ophthalmologist. Now, this insured ophthalmologist was not actually on call that day at the hospital. but took the phone call and was told to send the patient to the office the next day where they would be examined. The ophthalmologist didn't recall the specific details of what he was told and did not take any notes about the call. So on the following day, the patient was diagnosed with a chemical corneal abrasion and corneal edema and referred to the university ophthalmology department. At the university, the patient was treated with more irrigation of the eye after the pH was measured at 11. A placental graft was placed near the limbus, and the ultimate best corrected visual acuity was 20/25 - 1 in that eye. The plaintiff expert argued that there was an inadequate phone consultation with the emergency physician and that the ophthalmologist should have advised the emergency department physician to check the pH prior to discontinuing irrigation, and said the ophthalmologist should actually have come in to personally examine the patient, and also criticized care the following day when the patient was seen in the office and said the ophthalmologist should have checked the pH prior to sending the patient to the university. The defense expert said there was no real indication in the hospital records of what the chemical was to which the plaintiff had been exposed, and said most of the damage would have occurred immediately after the injury anyway, and questions why the emergency department did not refer the plaintiff directly to the university, since the ophthalmologist they were calling, the insured, was not actually on call, and said that the vision ultimately was not significantly impacted by the chemical injury. The outcome in this case, mediation took place, and the insured agreed to pay some costs to the plaintiff attorney, with total expenses in this case being $69,000. So, Anne, the risk management issues?
Thanks, Dr. Wiggins. So you don't have a duty if you're not on call. There's no legal duty we're aware of, and assuming this is not your own patient, to provide advice or care. If you do it occasionally, be very careful, because the Office of Civil Rights of HHS pays attention to that, particularly if there's a difference in the ability to pay of the patients you do and don't see. This case and the one before raise a lot of issues about telephone care. And the important thing to realize is that telephone care establishes a physician-patient relationship if it's about a specific patient. So you're called and said, patient Ann Menke presented with complaints of. However, if you're called and asked your opinion on an issue or about what your usual practice is, this is not providing care, does not establish a relationship. And I've given a couple of examples there of things you might be asked, which can't possibly, lead to what this physician should do for this patient. So there's a relationship created. What do you do? You have a duty of ongoing care unless otherwise specified. So you're saying, okay, this patient sounds like the patient had a severe chemical burn. I can't treat this. Go send the patient immediately to a university hospital. You're expected again to provide reasonably prudent care, drive the conversation, make sure you're satisfied with all the information you get, and then follow up. So we recommend you treat each telephone call as an office visit, obtain a careful history, develop a differential diagnosis, rule out the worst case scenario, and if you can't, it's prudent to examine the patient. And again, please document these encounters. Final case, duty to follow up.
This last case involved a 3-year-old child with a visual acuity of 2300 in the right eye and 20/30 in the left. The ophthalmologist made a diagnosis of amblyopia in the right eye and recommended patching treatment of the left, and a handout on amblyopia was given. The first follow-up visit 1 month later found that no patching had been performed, so a recommendation was made to patch the left eye a half day after school and to follow up in 6 weeks. Well, the family called to cancel the follow-up appointment and advised the office that they did not wish to reschedule an appointment at that time. Well, the patient returned 4 years later, and the visual acuity was now, count fingers in the right eye, best corrected to 20/20 in the left, and glasses were prescribed to treat anisotropic amblyopia. A claim was filed alleging the practice should have followed up to schedule another appointment, and the practice should have, or the physician should have explained the window of opportunity to treat amblyopia more completely. The plaintiffs argued just that the practice should have contacted the plaintiff to schedule a follow-up appointment. The defense expert said that the diagnosis and treatment were appropriate and that it was the parent's responsibility to reschedule the follow-up appointment. This case was dismissed, but as with any malpractice claim, time and money are involved, and the claim expenses for this case were $25,000. Ann?
So we're almost there. Thanks for hanging in with us. How much follow-up is needed and when it's needed is a question we get all the time. So if you have an established physician-patient relationship, then you do have a duty to follow up. And it can be established by your office scheduling an appointment, by a phone consultation, or an exam. The other time you have a duty to follow up is if there's an expectation of ongoing care. The most high-risk situation example is ROP, because the infant is known to be at risk for the disease and the possibility of needing treatment for a specific period of time. So during that period of time, unless you formally transferred care to another ophthalmologist, there is an expectation of ongoing care, and that's been proven in many lawsuits. If it's a postoperative period, there's an expectation of ongoing care, and is in the case we just discussed in amblyopia, which has a longer treatment window than ROP, but still there are some limitations on that, and your duty follows you until that is finished. How much follow-up? For most situations, we recommend one call, one letter. The staff tells you the patient didn't show up. They call the patient. If you don't get an answer right away and the patient doesn't agree immediately to come in, go directly to a letter that you send via regular mail. It should state the condition, what treatment is needed, really importantly, when is it needed, and what will happen if the care is not obtained. There are sample letters in our non-compliance toolkit. But if there's a risk of acute severe vision loss, more follow-up is needed. If it's a child, you might consider contacting CPS. If the patient is a dependent adult, you might also contact the Adult Protective Services. And in this case, we do recommend calling again and sending a second letter stressing the urgency and copy other physicians who might be involved in the care. How can you reduce this follow-up burden? First, schedule the appointment before the patient leaves the office. And if you have a staff who are reviewing those appointments, you'll know if the patient doesn't come in. Provide a prescription only for the appropriate interval and make the patient return for an exam and a refill. Here are some resources that might help avoid some of the situations we discussed. I forgot to add there that we do have an amblyopia agreement and letter to the pediatrician. That's also on our website. We don't have the opportunity to take questions, but if you have any about the talk itself, you may email me or call me. If you're an OMIC policyholder and it's about a specific patient, we recommend that you contact the hotline either by riskmanagement@omic.com or by calling the phone number there. And our website is open access, and you may use it whether you're an OMIC policyholder or not. I'd like to thank Dr. Wiggins for suggesting the topic, for helping me develop this course, and for co-presenting it with me today.
Thanks, Ann. I appreciate the opportunity to present with you.
My pleasure, Bob. Take care, and I hope for those listening that this has provided you with some useful information.